Kolay gelsin. Akşamın son saatleri fakat
Good afternoon. It is the final session of the afternoon. Tonya White yesterday talked about infant brain development in the womb and talked about diet and smoking and those periods when brain development is at its very critical stage, and also talked about plasticity and put emphasis on this, warned us about this. And today she will be speaking about cohort studies in children and adolescents. What do we know and what do we need? What are the deficiencies and our needs? This will be her topic of presentation. To introduce her briefly, she's both an engineer and graduate of Faculty of Medicine, a physician. And in child psychiatry and pediatrics, she is specialized, and she's currently working at Erasmus University. Now we are inviting her to the floor to hear her presentation.
Very few. And I want to thank the course organizers for inviting me here to give this presentation today. And I actually had a very lovely day touring parts of Anatolia, seeing old amphitheaters and museums of sculptures. So it was really very pretty and very excited about now sharing work that we've been doing and talking more about cohort studies. I do want to say that that if you have questions as I'm talking, if there's something that I'm not saying that is quite clear, feel free to raise your hand and say, hey, Tonya, I have a question. We're a small group, so I almost wish we were sitting around a table as we had this discussion here. But first of all, disclosures. None with the pharmaceutical industry. I do have a number of grants, and then I have journal duties, and I'm on the scientific advisory board for the Bergen Center for Brain Plasticity, which is a very novel 4-day treatment program for obsessive compulsive disorder. So I'm going to be talking about the intersection between epidemiology here, and in my case, it'll be developmental neuroscience. So epidemiology is in the news a lot these days with COVID. The World Health Organization, the Center for Disease Control are saying many things. But epidemiology also has a role in population neuroimaging, which I will describe, and describe the cohort that I'm involved in. So to go back in time to kind of give you an idea of the founding of epidemiology, and actually to show you the very first brain imaging, no, not brain imaging, it's not a brain imaging. It's an imaging study from the mid-1800s, kind of the start of epidemiology. You had in London, in the mid-1800s, you had a cholera outbreak in the Soho district of London. And there were a number of deaths here, similar to the COVID outbreak. And Dr. John Snow went around and tried to figure out why there was this peak in deaths. And here's Dr. Snow. So what he did is the red dots here are the deaths due to cholera, and the blue dots are the water pumps in the city where they were able to get their water. And what he found was that there was surrounding this pump on Broad Street here, there was a number of deaths. And then they closed off the pump, and and the number of deaths declined. So this is the kind of the first study of epidemiology, the study of epidemics. And actually, you could draw a line, I'm sure, between this pump and all the distances here. I've never seen that done, but you could. And then show that, that they circle all the red dots. So what about population, so epidemiology and developmental neuroscience? What about this? There's a lot of pediatric, very large pediatric brain imaging studies. And I hope I have all of them, but there's one that are classified as typical development. So they include only children who are pretty much healthy. So they exclude any children with psychopathology, with medical conditions, with seizure disorders. There are also clinical high-risk groups. So ABIDE is for autism. You have the Brazilian high risk. So they're either genetic or behavioral at risk. They're recruiting children who are at a risk for developing a psychiatric disorder. Then there's these that I'll call population-based studies. And I'll go into detail what makes a study population-based. There's twin studies, and then there's the large Enigma consortium. But when you look at the population-based studies, there's two of them that actually start in prenatal life. And that's the Generation R study and the Gusto study. So I'm going to talk about, first go on to the Generation R study. This gives you an idea. And I'm going to describe the inclusion criteria because that's one of the key factors that makes a study population-based. So it's a prospective cohort study in Rotterdam in the Netherlands in which all mothers within this zip code in blue were invited. So the inclusion criteria were you had to be pregnant with a delivery date between 2002 and 2006, and you had to live in this zip code. And that's it. That defines this population here. About 60% took place, which is quite high. And then the plan is to follow the children to young adulthood and to describe abnormal patterns of growth and development. So unlike what I did before I moved to Minnesota, before I moved to Rotterdam, I was in Minnesota and I moved to Rotterdam. Typical developmental neuroscience studies, you have a hypothesis, you recruit a sample to test your hypothesis, you do the analyses, and you write your paper. Epidemiological studies are different. You say, I'm going to collect as much data that I think will be beneficial, and then you collect the data and you address questions afterwards. I'll show you examples of that. So Rotterdam is a quite ethnically diverse city where Dutch and other European are 58%. You see about 1 in every 10 people are Turkish in Rotterdam. And I said this yesterday during my talk, but also it feels like a Turkish city if the Turkish football team's playing because there will be more Turkish flags in Rotterdam than anywhere else. So that's another important point about population-based studies is you try to make your population generalizable so it fits the population that you're studying. And so then the research questions that you can ask apply to all different populations, whether it's SES, ethnicity, race, other factors. So one of the goals of population bias is to try to decrease different types of population-based studies, try to decrease different types of bias, and especially selection bias, which you try and include as many people as possible. So we, in the Generation R study, had 60% of mothers participate, but it's very possible that the 40% who decided not to participate are different than the 60% who did decide to participate. And we can look at some of the things related to records from the Dutch system to see how well they match. The other important point bias that we try and prevent in longitudinal studies is attrition bias, so loss of participants in a non-random fashion. And if you can imagine, oftentimes in the studies that we do, the individuals that we want most want to remain in the study are those that are most likely to fall out. So if you have a child with autism spectrum disorder, it's difficult to do everything, and then you're involved in a research study along with all the other things that you do. Or if you're divorced and then you're a single mom with children, and then it also becomes difficult. So we try attrition bias. So exclusion bias we tried to prevent by including everyone within a certain region. And then there's other types of bias that are important to know about. Reporting bias, bias due to the ways the data is analyzed. Funding, these two are unethical. This is funding bias, is why I told you my disclosures. And then career enhancement bias, which is playing with the data until you come up with a positive result, which is also unethical. So how well did the Generation R study do with respect to reflecting the sample of Rotterdam? So here's our total sample of 9,901. And here's ethnicity. And here's the Dutch population, the non-Dutch Western, or non-Dutch non-Western is here, and the non-Dutch Western, and this is, they didn't report it. And here we also have maternal education. So these are our two brain imaging waves that we have, but our first wave doesn't quite match. Our second wave matches better, but it's not completely overlapping. So you can see that there's some level of bias. So what we try and do is we can try and control for this to make sure that we account for these differences in the population not necessarily reflecting the population of what we're studying. Okay, what I'm going to do now is I'm going to run through in a kind of a rapid fashion. This started in 2002 to 2006. We've collected many different measures since that time. Let me kind of walk through the different types of measures that we've collected so you get an idea. So our first brain measure began in ultrasound, where we had at first, second, and third trimester, we had head ultrasound. And then at 6 weeks, you can see here, we had an ultrasound in a subset looking at, through the anterior fontanelle, looking at specific regions. So you can see the corpus callosum, and this structure here in ultrasound terms is called the gangliothalamic ovoid. So you can get different measures, and it's a measure of the subcortical region. So here's the dates for that, and then we had cord blood. We actually had blood collected at multiple time points. Hold on, I'll get to the blood here. So we've had blood collected at multiple time points in the study. Questionnaires, the parents actually should get medals for how many questions that they filled out. Thousands and thousands of questions over the now 17 years that the study's been going on. And the questionnaires cover a lot of domains. So they cover quite a bit of detail during prenatal life of many different factors, but also postnatal, including child temperament, behavior, sleeping habits, sports, television, cognition, psychosocial characteristics of the parents. We even have the Ainsworth-Strange situation in a subgroup of 1,000 children, where all of them came in and they participated in that to measure attachment. One of our key measures of behavior is the child behavior checklist, so we can use repeated measures, looking at behavior over time, looking at trajectories of behavior, looking at how certain symptoms, characteristics change over time. We saw that in the keynote presentation, where children and adolescents may have different presentations as they develop. So we'll have a prospective study. I have a PhD student who, it's her idea, and she's wanting to look at how that changes over time. Different types of cognitive measures, working memory, nonverbal IQ was done at age 5. Where we have IQ of the mother to use as a covariate. And I'll show you how we use that in an example later on. And the WISC-5 we just completed in about 6,000 children. It are 13 to 15-year-old wave. And COVID kind of has, for everyone, has caused problems. So we had to shut down for a while, and we've started up again, kind of gradually building, but it's going much slower than what we were hoping for. We had during prenatal period interview on mothers to assess depression, and then the Berkeley puppet interview was done between 5 to 7 years of age. This is to remind me that I'm going to talk, most of my talks about mental health, but this is not just mental health. This is other disciplines. This is pediatric dental, ophthalmology, pulmonology, growth and development, immunology, many different disciplines all working together. And it's both a blessing because you've got lots of data in different domains, but also it means that you're kind of battling for time, the amount of time that you can have with each child. So for imaging the whole brain, I have 30 minutes to do everything I want to do, which you can get some things, but I could have thought of a lot more things that I would like to collect in that time. And MRI, so I'm going to get into the MRI. So we've started this slowly. This has actually just started in the last couple months. Our 4th measurement of MRI. And that's why I came in 2009 from University of Minnesota to set up the neuroimaging program in the Generation R study. So our first wave was 1,070, but it was, you saw from one slide that it's a little bit biased because we had specific grants to study specific children. So children exposed to cannabis during pregnancy or smoking, dysregulation disorder phenotype. I'll show you some of the results from that. And then we were able to acquire our own dedicated research scanner. And at that point in time, we were scanning up to 130 and 170 children per month. It was like an assembly line where the children came in and they went through the scanner, and it was quite the process. And then we began scanning wave 3 in October 2016, and we've scanned about 3,500. That's wrapped up now. We're starting the 4th wave, and we're working on cleaning up the data and getting it processed. It's big data. So what do we collect? We collect a high-resolution structural MRI scan, seen here, a diffusion tensor imaging scan, and a 6-minute, 2-second resting state scan. So those are the 3 things that we can squeeze in the 30 minutes. Actually, we started an arterial spin labeling sequence because another group wanted to do that, so we were able to get that in. So when the children were younger, the question is, how did the children do in scanning? They're 6 to 9-year-old children when we first started. Now they're teenagers and they climb in and it's not a problem. So we had different type of toys that they could play with to kind of get used to that. And this is our practice MRI that we would run them through in a practice MRI scanner so that they could get used to the environment. They could actually hear, here's headphones, they could hear the noise of what the scanner was like. And one of the PhD students started showing the children this was on a kind of a piece of paper, one image with it crystal clear and the other image if they move a lot. And that seemed to help them try and stay still during the scanner. Seemed to work. We didn't study it though. So we also had, we worked with our medical ethics board because they were concerned about putting young children in the scanners. So we devised a system that we would use in which that both before the MRI, before the practice MRI, after the practice MRI, and after the real MRI, we asked them how they felt about being in the scanner and whether they were really scared. If they ever pushed a 5, then we stopped. And the children knew that. They knew that if they pointed to a 5, we would stop. Sometimes the child would point to a 5, and the parent, the mother or father, would say, no, 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 we want to go, we want to do it, we want to get the MRI. But we'd stop. So if the child said no, then we stopped, and the children knew that. So then the question is, how did the children do? What did they point to? Here's the 0, 1, 2, 3, 4, 5. So here's the rating scales. So this is before our mock scanner or practice scanner. This is after the practice scanner. And this is after the real MRI. So you can see here's 5. Not many children pointed to 5, although a few pointed to 5 after the scan was over, which means we had already collected the information. So that's unfortunate that they felt that it was bad afterwards. But most children actually did extremely well. Children do better than we think they're going to do. And how do I know that? Well, that's this slide here. So here is the level of anxiety of how the children rated here. And here is how the parent and the researcher rated the child's anxiety. So the parent and the researcher thought that the child was actually more anxious than at least what the child rated themselves. So maybe the monsters in the closet are more for the parents than for the children themselves in this case. Now, movement is a problem. And this is actually a slide showing not the mountains, the sea and to the side and the mountains, but this is actually during our resting state scan. You can look at movement during the entire time that they're in the scanner. And this is 160 volumes of MRI data that we collected. And you can see this is our 6 to 9-year-old sample. And this is rank ordered on mean movement. So whoever this child is here on the first row hardly moved. They get the prize for being the most still. And here are your children on the very end where they move a lot in the scanner. So there are some children, we lose quite a bit of data because of movement in the scanner. Children with ADHD, or you would expect to move more, but they actually didn't. So we expected. The one other finding is that we had a study when we were collaborating with the group at Nijmegen and on children who were exposed to SSRIs during pregnancy. And about half those children actually didn't even want to get into the scanner. So we couldn't actually do the study because they were too afraid to get into the scanner. Okay, so within my group, I have 5 major research lines. Yesterday, I talked about this first one fairly in depth, and especially the story about folate. And today, I'm going to give you a tour of the other ones, a whirlwind tour, so to speak. So autism spectrum disorders was the autistic and Asperger's, and with the DSM-5, it's now combined into autism spectrum disorders. And it's a combination of social communication problems, and the peak presentation is between 1 to 3 years of age. So what about the brain in autism? There's been studies looking at brain growth, and there's also been studies looking at measurement of orbital OFC, orbital frontal circumference. But if you look at the brain imaging studies, there's a tendency for this overgrowth of brain during, here's the actual data, early in life. So actually right around 2 to 3 years of age, there's this overgrowth, and then it actually decreases. It's been shown by Eric Krishane and Heather Hazlett from Joe Piven's group. Both of them have shown this overgrowth on MRI. The data on head growth using tape measures is a little less clear. It seems there's definitely a subgroup of individuals with autism who do have the overgrowth, but it may not be all of them. So we asked the question, what happens during prenatal life for the children who later develop autism? So it could be that this overgrowth that occurs later in life is a sort of rebound phenomena to something that occurs during prenatal life. So you have an event in prenatal life, and then there's some event that occurs. And so we combined with the RAIN study in Australia. They had 870 children. We had 2,950. We used the social responsiveness scale and the autism spectrum quotient. So these are two population-based studies, and we looked at ultrasound measures to see what is head growth for autism during prenatal life. And we actually found no difference in prenatal growth trajectories. In the Generation R study, we did find a decrease in the 3rd trimester, but it wasn't replicated in the RAIN study, and therefore it was a negative study. So the other, I'm going to stay on autism for a little bit. The other important thing or interesting thing that can be done in population-based studies is that you can look at psychopathology across the spectrum. So, for example, most case control studies, looking at autism, for example, they'll look at this group of clinically impaired versus this group with no problems. And these children typically are excluded from those studies. But in population-based studies, you also get children who are not necessarily help-seeking. And then you can ask interesting questions like, is there a dose effect of autistic symptoms? So if you have subclinical autism, do you have subclinical brain changes? What is the nature of the relationship? Is it a continuous relationship, or is it nonlinear? And these types of questions you can answer in population-based studies. So we're looking at, we did a study looking at cortical morphology underlying the broader spectrum of autistic traits. And John Constantino at Washington University of St. Louis, although some people have argued against this, says that autistic symptoms is a distribution in the population, with one end of the population, the individuals with autism, just being at the end of this distribution. That's certainly not true for children with de novo mutations and other things. But so we wanted to test whether, so we looked at cortical morphology, autistic symptoms across the spectrum, so linear. Then we used our data to look well, are these, if we emulated a case control design, would those findings also be there? And then to see if it really is a more continuous, we dropped these children on the clinically impaired spectrum to see, even if we include these, would the relationship still be there? And what we looked at is cortical thickness, where we didn't find that much, and gyrification, which we found quite dramatic differences. The patterns were very similar between boys and girls. And in areas of where you might expect superior temporal lobe, inferior temporal region where the fusiform gyrus is, precuneus. So, but it was rather global. We've since repeated this in our subsequent waves, and we've actually done a longitudinal study that has been submitted, but is still under review. So here's the question. I guess I'll show you here. Here's our measure of brain morphology. It's the gyrification index here. That's on the y-axis. On the x-axis here is, as you go this way, you're going greater level of autistic traits. So then you're asking the question, is it a continuous relationship? And this is the left hemisphere temporal precuneus. Is there a continuous relationship that as you go higher in autistic traits, do you see a linear change in brain features? And in this case, for the left hemisphere temporal precuneus area, you actually do see exactly that. The more autistic traits you have, so there's some, whatever's involved here in this level of the brain, a more continuous. So having more autistic traits results in more changes, but not all of them do that. This is the right hemisphere temporal frontal region, where here it's pretty much all along the same line, and then once you have this clinically impaired group, then you see the difference. So the story is a bit mixed as far as this goes. We also looked at a neuropsychological assessment. So with actually the very same question. So if you look at the cognitive profile of children with autistic symptoms and autism spectrum disorder, does it follow a continuous relationship, cognitive profile, continuous relationship? And we found that cognitive symptoms also did. Actually, I was kind of hoping when we started this study that there'd be some cognitive benefit in some of the domains with children with subclinical autistic symptoms. I thought this would be cool. Wouldn't it be nice to have an inverted U type shape so that if you had some autistic symptoms, there's some cognitive benefits? But that's not what we found. We found, and the difference between model 1 and model 2 are just different covariates that we included in the model, but it didn't actually change it that much. So you can see across multiple cognitive levels of functioning, you see decrease in, and this is a z-score here, and 0 here is the reference group, or yeah. So, and that tended to also be a continuous relationship. Now let me move on to emerging psychopathology. And I'm going to talk about the dysregulation disorder phenotype. And I'm going to describe this as an area of emerging psychopathology because, well, I'll get to the prior studies, but the children have problems with attention, aggression, anxiety, but it's fairly non-specific. The prevalence has been 0.7 to 2.5% of the population, and there's high heritability rates of this seen in twin studies. But what's interesting is that there's been a number of long-term follow-up studies of children with the dysregulation disorder phenotype. And the blue area marks how long the follow-up is. This tells you the number of participants in the sample. And for example, this is 2,076, and it was a 14-year follow-up period, and reported by Rob Althoff in 2010. But what's interesting about the dysregulation disorder phenotype is that it's an at-risk profile, but not for any one specific psychiatric disorder. It's for mood disorders, substance use disorders, personality disorders, and anxiety disorders as well as others. So it's a non-specific classification, and children are differentiate as they go on, but it's still an at-risk state. So we looked at, can you identify these children in the Generation R study using a latent class analysis and identify who are these children with a highly problematic behavior as rated by the Child Behavioral Checklist scale. And this is looking at where they are on the scale. The black is the no problems group. Then you had the externalizing group in green, internalizing group in blue, and then we had this group that just actually, they're the children that score high on most domains of problem behavior. And there's been studies coming out with the P factor. These are going to be the same children that score high on the general P factor score if you see papers in that area. So what about cognitive functioning in this group? So if something has such a global effect on behavior, then it makes sense that it might have a global effect on cognitive functioning as well. And that's what we found. So this is nonverbal IQ in our entire sample, some 5,500 children. And here's the IQ score here. We found an 11-point difference in IQ between those children with internalizing problems, or dysregulation, and the no problems group. And it was far more than the other groups. So it might make sense if there's something going on with behavior globally, there also appears to be something going on with cognition on global. It's all in the brain. What we also did was we tried to say, okay, what if we removed the genetic and environmental effects from this? What if we covary, we control for the parental IQ, or IQ of the mother, to try and remove the genetic effects of that, and then parental psychopathology. And it did explain some of the variance, so it went down to a 7-point decrease, but that's still half a standard deviation. So if they have fairly dramatic differences in global cognitive functioning, they should have fairly dramatic differences in brain. So, this was our cognitive assessment. I should have put this, different domains using the NEPSI-2. That's the domains that we covered there. And we also found, kind of in these children with dysregulation, looking at our neuropsychological test, patterns that the black is the control, especially in areas of sensory motor and attention and executive function. So, but what I wanted to talk about here is, so here is structural MRI, diffusion tensor imaging, and resting state. So they have fairly global differences in cognitive function. So what about the brain? Well, interestingly enough, we found nothing with structural MRI, nothing with diffusion tensor imaging, and nothing with resting state. So maybe, so I currently have a grant and a PhD student who's looking at why, what's the reason why we don't see anything in the brain for these studies. It may be that they're just so heterogeneous that we didn't find anything. Or things may emerge over time. So this was a little bit puzzling. Or the stability is of this, it's not all that stable early on, but we saw that it's a risk for a follow-up. So this is still ongoing. Now I'm going to talk a little bit about imaging genetics, and I'm going to specifically talking about polygenic risk scores for psychopathology. So we collected data from the polygenic, from the PGC, the Psychiatric Genomics Consortium. And our first study, we looked at child behavior checklist measurements at 3 different ages. And so what we were looking at here is, does a polygenic risk score for a child? So a polygenic risk score is built from many, many genes. You can have different thresholds, but it's including many genes to develop one score for a child who is at genetic risk for a specific disorder. And you do that in an independent sample, in this case, the Psychiatric Genomics Consortium. You develop weights for each of the SNPs, and then you apply them to your own data to develop a score for each child at what their risk is for example, schizophrenia, what the risk is for autism, what the risk is for ADHD. So that's a polygenic risk score. And here's our measures of psychopathology that we used. So we had a polygenic risk score for schizophrenia, major depressive disorder, bipolar affective disorder, autism, ADHD. And then this isn't, I guess you wouldn't be at risk for high educational attainment. That would probably be at resilience for high educational attainment. But we also have a measure of educational attainment from independent studies where you can get a polygenic score for all of these. So how do they play out? So this is a busy slide, but let me show you. So this is internalizing and externalizing. So first of all, this one is our first wave of data collection. So this is one and a half, 3, no, I'm sorry. This is 3, this is 5 to 7, and this is 9 to 11 years of age. So these are different ages. Each one has a different age group. So if you look at what is the polygenic risk score for schizophrenia for externalizing score at 3 years of age? And you can see for schizophrenia, it was significant. For ADHD, only for the internalizing score. And educational attainment was also significant at the 3-year-old level. Interestingly, it actually gets less over time. Schizophrenia becomes, so this is the 9 to 11-year-old, and you see it more with internalizing score and with educational attainment. Actually, educational attainment was just with the externalizing score at that point and not the internalizing score. So it looks like even at 3 years of age, behavior, polygenic risk score for schizophrenia picks up some level of behavior at that age. Why it didn't, and that it changed also from here it's both externalizing and internalizing, and for schizophrenia it's only internalizing. And ADHD actually went away. So then we looked at the brain using diffusion tensor imaging, 35 direction DTI, and the tracks that we use are these major tracks in the brain. So cingulate gyrus and the uncinate fasciculus, and these are all major white matter tracks. we had 12 tracks that we extract from the brain. And here also we found, actually with our polygenic risk score for ADHD, we saw differences in white matter in the brain related to the polygenic risk score, and then educational attainment, which is by far the most striking, in which higher fractional anisotrophy, which is a measure of white matter microstructure, was related to better cognitive performance. So those children with, genetic resilience for higher educational attainment had higher white matter. Okay, I want to end with, so we've covered all of these with typical development, a bit of typical development and methodologies. And I just want to, one of the questions, we hear a lot about resting state fMRI, but one of the questions is, how long do the children need to be in the scanner? How long do they need to be there before you can get good resting state networks in children? So that's a question that we ask. So what we look at in fMRI for resting state is functional connectivity. So it's, if you have two regions that are wired together, the thought is that they also fire together. So regions that are connected will have similar patterns in the activations that we see on fMRI. And actually it has to do with differences in hemoglobin and oxyhemoglobin. But you can look at different regions in the brain and say that they're functionally connected. So here are typical networks in adults. You have a motor, visual, extrastriate. And we went and looked at our sample of the generation R and say, well, do we get these same networks with the sequence that we are currently using? And actually, so we do get a nice primary motor network here. We get, rather than two different visual, we get one visual network. We do get this insular ACC. The left and right parietal prefrontal come out actually really nicely. The default mode network we actually also see almost always. So oftentimes it's split between an anterior and a posterior region. So you get this splitting in children, which we found in many of our children, but not all of them. And we also get a frontal region. So in general, the functional networks that we get when we extract using independent component analyses, we get very similar to what is seen in adults. So, and then what is how long do we have to scan children to get really good resting state networks? So here are these different networks that I just showed you here. And this is time in the scanner. And this is how long does it take them to reach a certain level of stability. And actually, we use this data to actually change our scanner time to around 6 minutes, because we found that actually after around 6 minutes is when we had good stable. But some networks were stable pretty much right away. So here's the insular temporal ACC. This is a measure of spatial overlap. And some measurements were really quite noisy and took quite a long time to reach some level of stability. This gives you an idea of if you have 5 minutes and 20 seconds versus 8 minutes and 8 minutes, 20 seconds, how well the overlap is between the different images here. And you can see you extract even at 5 minutes and 20 seconds most of that. And then you get, there's added benefit for going longer, but it's a trade-off because you also get more movement. Because we also want the children to be in this, not to be in the scanner too long, because then they move more. Okay, and then we also, Sandra Lungeslag, who's now in St. Louis, we looked at this notion of a PFIT. So in adult literature, there's this theory about IQ that it's involved with the parietal prefrontal integration theory, the PFIT theory. And so we wondered if we saw this same phenomena in children, that this connectivity between the parietal and prefrontal regions were there with IQ. And actually, yeah, here's the results, but we did find it. We found that the right frontal network was correlated with IQ. So I'm going to end there. I'm a proponent of data sharing. This is kind of DTI humor, I think, but data sharing has a number of benefits, including people who can't do all the imaging in large samples like we do, can access data. And there's quite a bit of open science approaches. And not only that, if you ask me what I think the future is going to be, it's going to be delving more into machine learning algorithms, which is going on in the field of dermatology right now. And because it's easy to take pictures of images on the skin, and it's going to move into radiology and probably change the field of radiology. It's not going to remove radiologists, but it's going to make medicine much different. And part of that is done through being able to get your hands on large amounts of data. So in summary, so this merging field of epidemiology and developmental science, developmental neuroscience, is really an interesting field. And what I talked about yesterday, it's one of the fields in neuroimaging where there's a direct translation to public health. And I showed that yesterday with folate. But also smoking during pregnancy. The results were there. Depression during pregnancy. But there's also numerous challenges. And then now the question is, what do we need? What do we need for these cohort studies? If you here in this room, if we went to a small room and said, we're going to develop a cohort study in Istanbul, and we're going to recruit everyone in the entire city of Istanbul, mothers who are pregnant, and we're going to stop smoking during pregnancy. A major goal would be nice, right? So what would be helpful are more frequent measurements, because some of the measurements we have only once, for example, serum folate, collecting data, larger populations with greater variations in race and ethnicity, we're actually doing quite well, but how generalizable is it? Digital phenotyping approaches will be very helpful, so using the iPhones to do different things, if you want to know activity levels or mood or things, that we're seeing that happen now in some place. More continuous measures, because they tend to have more power. Objective measures as much as possible, genes, epigenome, biomarkers. And then what would be really cool, if you want to know what do we need, let's have an intervention, population-based intervention study where you actually change things. We say, okay, so I bring up smoking. I talked yesterday about smoking, but smoking during pregnancy, because in the Generation R study, when we look at, for example, alcohol and use and brain development, if you look at the, and I talk about the Turkish and the Moroccan populations, no one's drinking alcohol. It's just not a problem in that subgroup. If you look at smoking during pregnancy, then they do much more than in the Dutch population. We were talking yesterday around the table, and it sounds like it's not just something that's happening in Rotterdam, it's also happening here for some reason. So that would be a public, so how would you, on a population-based level, intervene? So smoking is there, but alcohol, other substances of abuse, decreasing stress. So there's a number of studies now looking at stress. So I'm going to end there and ask if there's any questions. And if the... Yeah.
Is there any question? Yes.
Very, very interesting set of findings, really, and research. Well done. It's more complicated than we thought, isn't it, really? It's not come out with the startling answers you perhaps wanted to... But can I ask, because I'm not so familiar, what was the emotional dysregulation? Was it emotional dysregulation or behavioral dysregulation or what? Was it a combination of...
It's behavioral... it's a combination, actually. But in our study, it was measured by the child behavior checklist. And the traditional measure is that you're high on one of three scales. Anxiety, depression, aggression, and attention problems. And traditionally, children who are high on those scales fit the dysregulation profile. However, when you look at it more empirically, those children tend to be high across all measures. So, so those are just, as well, what Gay Carlson describes, these are the sickest kids. These are the children that you see in your child and adolescent psychiatry practice when they're younger, who are just emotionally dysregulated, and they don't fit any one specific category. But this is a population-based, and rather than a clinical-based. Does that answer your question?
Yeah, no, it certainly does. I mean, one of the... you've gone up to age 13, is that right?
We've gone up to age 15.
You are now at age 13, is that
Well,
right?
you mean on our data collection or on studies that we've done?
Yeah.
We're now writing papers with the 13 to 15.
Yeah.
We finished we studied 9 to 11. It's all in cycles. So we finished data collection about a year and a half ago on the 13 to 15, and then it takes quite a bit of time to process all the data and quality check all the images and do all of that. So, and now we're starting our scanning the 17 to 19, which would probably be the 19 to 21.
Can I just ask what the effect of puberty has had upon some of your measures and so on like this? Have you analyzed that?
So we're not allowed to, we're following the children, so it's treatment as usual. So if you ask about treatment, it would be treatment that we've collected via what treatment that they've had. And that data is not, we've wanted to link each child with their health record or get records from the primary care physicians. Actually, for the autism diagnoses, we actually went to the primary care physicians and acquired the data from them. So it took a lot of work. But unfortunately, the Netherlands also doesn't have this global pharmacy records that you can just link to one database and you get all the pharmacy records. It doesn't, unfortunately, have that. So the treatment will be via questionnaires that we give them. What does your child have? What have they been treated for? And then individual collection of pharmacy records.
I suppose one of the other things that really strikes me is that Netherlands is quite a affluent country, isn't it? So, and good social supports and things like that. So, I mean, although there's maybe some social deprivation and things like that, it's not major, is it going to be? You don't have major social deprivation in this group, or do you? Just a question, really.
Not like the Bucharest high-risk project or other things where there's large levels of deprivation. No. I mean, you can look at, and even within groups that are more isolated, different ethnic groups in Rotterdam, there's still a lot of support for different groups. So, yeah, it's a population-based study where we're looking at differences that are sometimes rather mild.
Başka soru var mı arkadaşlar?
Any other question or comment?
Thank you for your findings, to share your findings and study.
Thank you for the opportunity to speak. If you have questions afterwards, feel free to come up and chat with me. So, and I'm sensitive about language because I've lived in the Netherlands. I had to learn Dutch. I know sometimes people can be self-conscious about language. I hope I'm kind in that.